Okay, Judy, I think we have kind of a critical mass at this point.
Okay.
And good morning, everybody. We're going to go ahead and get started. I'm going to start putting the links to these webinars today on the webpage for the course. That's spice.unc.edu/IC Part 2. So take a look there, and as I'll be adding them during Judy's webinar for easy access to these sessions. So we're going to start off this morning and welcome Judy Bringhurst, who is the Infection Preventionist and Safety Officer for the University of North Carolina at Chapel Hill. She works primarily in the ambulatory surgical centers, physician practices, and specialty clinics. She received her BSN from University of North Carolina and her master's from Duke University School of Nursing, and has served a 3-year appointment to the Association for Professionals in Infection Prevention and Epidemiology Annual Conference Committee, specifically representing ambulatory care needs. So welcome this morning, Judy. We're so pleased to have you, and thanks for participating in our webinar process.
Thank you, Amy. I don't think I have control of your screen though, Amy. Could you switch that over to me?
I sure will.
Thank you. And while Amy's doing that, good morning, everybody. Thank you so much for working with us on this. Who knows when we're going to have a major hospital lose all of its water. It was really a pretty amazing event that I have never experienced in my 15 years as an infection preventionist, so it's been a real learning curve for all of us. Of course, water, just because we're all students here today, water loss is a big deal, not just for hand hygiene, not just for patient care, but for instrument processing. We had to stop all surgeries yesterday. We couldn't process any instruments. We couldn't high-level disinfect any instruments. It was really a pretty amazing hit to the healthcare system. I'm trying to get back. Let me get you back to the first slide here, guys. Okay, so there we are. So let's go ahead and start in. First of all, Amy, thank you, and thanks, Spice, excuse me, for having me present our little niche on outpatient care. I do ask participants, please bear with us if you're not. Oh.
Okay, Judy, sorry.
Amy?
I think we lost a little.
There?
Yeah, we lost a little internet connectivity. Let's get back to the.
Okay, stand by, folks. There we go. All right, and let me click here. There we go. Okay, now let's see if we'll advance this time. There we go. Okay. So here's some objectives we're going to look at here in the next little bit. We're going to shift our infection prevention perspective. Those of you in the class that have been doing infection prevention for a while, you know, most of us are certainly historically, we were all trained in hospitals. None of us had any training in outpatient care. And of course, if we were face-to-face, I could ask how many people were going to have responsibility for outpatient care areas. But I feel certain that many of you in this class today will have some responsibility for outpatient care. So that's a very good thing, because historically it's been a really, really I'm going to say ignored. I'm sure there's a very much more politically correct adjective for that, but it's been a much ignored area of healthcare in America. So we're going to shift our infection prevention perspective from inpatient to outpatient a little bit. We're going to look at some statistics on outpatient care in the United States. We're going to look at, and we're going to focus on the two big bad things that can happen in outpatient care: unsafe injections and poor instrument processing. We're going to take a little bit of time to look at those two areas in depth. We're going to review some outbreaks. We're going to look at, of course, like I said, the instrument problems with outpatient care. And of course, we're going to talk a little bit about FDA, CDC recommendations related to scope processing and manufacturing. Okay, so let's jump in. So as infection preventionists, we are out there, whether you're an outpatient or inpatient, we are out there teaching, translating our vast body of research into practice. The main work of an infection preventionist, in my opinion, is to take all of that science we have and that we're aware of, and of course over the years and every day brings us new science that we need to be apprised of, but to take all that and translate that to that frontline healthcare personnel who's placing their hands on patients, who's drawing up medications, who's processing instruments. That's our number one job, to make that science relatable to what there are folks out there that are actually in practice. Now, in all that, that's a big order, absolutely. We cannot always make things perfect, and we're going to show you some imperfect situations, particularly when it comes to unsafe injections and particularly instrument processing. But we can always make things safer. I will guarantee that to everybody in this class today, as an infection preventionist, you will always make things better and safer. It may not be consistent with regulations and guidelines, but it will always be safer and better for your patients and for our staffs. Okay, outpatient care in the United States. More patients obtain health care in specialty clinics and physician offices in the United States than in hospitals. Let me say that again. By exponential numbers, more patients get their health care in America in outpatient facilities than in hospitals. And of course, the dark side of that is they've been traditionally ignored in terms of infection prevention. We're gonna see a few instances of what happens when we don't pay good attention to our ambulatory care areas. 1.2 billion ambulatory care visits in the United States. That's from CDC information from 2008. Now, that's much increased since then. That's 10 years ago. I would say easily, in fact, I think recent CDC data shows 2 billion ambulatory care visits in the United States. So almost 61% of those visits are to primary care physicians' offices. You know, these aren't specialty clinics. These are your family practice, your internal medicine clinics. And for example, in the University of North Carolina Healthcare, all of our outpatient sites had 1.7 million visits in 2015. 1.7 million arrived visits. Those weren't scheduled visits. Those were arrived visits in 2015. So the numbers are huge. Okay, defining surveillance. First of all, you can see my friend up there, the great genius, Albert Einstein. He defines, Langmuir defines surveillance as follows: the continued watchfulness over the distribution and trends of incidents through the systematic collection, consolidation, and evaluation of morbidity and mortality reports and other relevant data, together, important, with the dissemination to those who need to know. I am a large proponent of, if somebody's got a problem and they're not aware of that problem, it's going to be difficult for them to fix that problem. So we find ways to address that with our outpatient care areas, as well as our central processing departments and any other areas that do any kind of instrument processing. So when you change the way you look at things, the things you look at are going to change. When we switch our perspective out of the hospital and start looking at our outpatient care areas, things will change for you. Okay, so here's our University of North Carolina Hospital's infection prevention outpatient surveillance perspective. Here's our definition at UNC Healthcare. Inpatient, historically, they look at outcomes. We look at data, we look at infections, which you all know, we're talking about ventilator-associated pneumonias, surgical site infections, CLABSIs, CAUTIs. Those are the things we look at to a large degree, certainly not exclusively, in inpatient infection prevention departments. But when we move into the outpatient infection prevention arenas, we more so, very much so, look at performance and process measures. Now, I may say our inpatient infection preventionists have begun in the last 2 years to look at actual performance and process measures. So that's a very good thing, because as we know, that's where the rubber meets the road. Those are where the infections happen during performance and during processes. So our outpatient surveillance definition at UNC Healthcare is as follows. In UNCH ambulatory surgery centers, physician practices, and specialty clinics, outpatient surveillance is defined as bridging the gaps between guidelines, standards, regulations, and the actual practice of assessing infection prevention performance. And we do that by applying a standard survey tool, gathering and analyzing the data collected with that tool, reporting that data back to facilities, and requiring action planning to improve performance if their score on that report is less than 100%. And we're going to look at that survey tool and some of the data we've gleaned from those surveys. Well, gee, here we are. So on the screenshot there on the left, you can see just one page of our survey tool. The screenshot on the right, you can see where we gather all that data together. That graph has 4 years of data in there. Of course, now we've added almost 3 more years onto that graph. The graph is getting a little unwieldy. We're going to have to start breaking it up a little bit. But you can see it's a very, very effective way for us to monitor trends. So our outpatient survey tool, it compresses guidelines, standards, regulations, and the UNC hospital's policies into a usable 17-section comprehensive instrument, provides a survey score to the facility, facilitates data gathering, analysis, and correction of deficiencies. And I did see the question. I think Amy can address this afterwards. I believe this tool is available, and Amy will have the links for that tool for you. By the way, we have a 2018 version of this survey tool, which has grown significantly. It is a more comprehensive tool for an IP to look at. We're not sure how usable because it's so large. It is for our clinics to actually use, but for an infection preventionist, it's grown, and I think it's even more comprehensive than it is. Don't be afraid of its size. Yes, 17 sections, it's more sections now. That is its strength. Its comprehensiveness is the strength of that tool, and Amy will get that out to you guys. Okay, so let's walk through the tool here, folks. Let me turn some of my pages over here so I can get caught up on my desk. Very good. Okay. So you can see here just a little orientation to this tool. There's 2 columns there. We have the left-hand column. We have the right-hand column. The left-hand column, if you will, I'm going to use Joint Commission language. Many of us are familiar with that. And if you're not yet, don't worry, you will get familiar with Joint Commission language. The left-hand column, if you will, is the standard. A standard is a broad statement of what we're looking for. So the left-hand column would be the standard. The right-hand column, we call those the elements of performance. It's more detail on how to meet that standard that is in the left-hand column. So you can see now we have sections 1 and 2, infection control policies and procedures. We want to make sure staff has access to policies. They certainly can show us how to get online to those policies. We in fact discourage the use of notebooks anymore for policies because they change so frequently. I know we have a very dynamic policy regimen in our department. We go in and make little tweaks along the road, and of course the TB policy needs to be every year. The bloodborne pathogen policy has to be every year. Generally speaking, the rest of our policies are every 3 years, but we frequently go in before then and make changes as we come up against some issues in that policy. But moving on to section 2, hand hygiene. You can see there lots of information on hand hygiene, artificial nails, soap dispensers, paper towels, hospital grade waterless hand agents where appropriate, and you can see on the left-hand column, but then on the right-hand column, we have much more detail. Sinks in dirty utility rooms and other areas used for decontaminated equipment or disposal of potentially contaminated items cannot be used for hand hygiene. A note on that, sister and brother IPs, this comes up still very frequently. People simply do not know that you cannot rinse that dirty instrument off in a hand wash sink. We do still run up against that, and we've had to be very, very creative working with our clinics that are doing that. It's not our job to take their practices away. It's our job to make their practice safe. For example, recently we had pessaries. Those of you that have women's urology gynecology clinics, they do a lot of pessaries. The patient comes in with the pessary is removed during the visit. It's washed with soap and water. It's put back into the patient before they leave. That's okay. It does not have to be high-level disinfected. This is the patient's own equipment. There's no risk there for cross-transmission. However, we discovered that they were washing pessaries in a hand wash sink. So what we did, we worked with them closely to find us a workable solution for them. And we did come up with one. We're using one of those turquoise blue bath basins. For every pessary, they have to get a clean bath basin. They put the bath basin down in the sink. They run a little bit of soap and water into the bath basin. They wash it in the bath basin, and then they rinse it in the bath basin. And then that bath basin water needs to be taken to either a hopper, a clinical sink, hopper/clinical sink. There's two words for that. I think most of us in healthcare know what a hopper is. Construction calls those a clinical sink, or poured down a toilet. We've done multiple studies on sinks. We know they're contaminated, even with hand washing. And so we certainly don't want to be pouring any of the blood and body fluids we're getting off of patients down those hand wash sinks. So it was a couple of false starts and rejects to get that right with the clinic that was workable, but that has worked for them, and they've been great partners in figuring this out. Okay, so you can see down below, I'm moving on to E, about staff explaining hand hygiene policy, down to F, dons and removes gloves at appropriate opportunities, and of course lotions available. We want to make sure we have lotions available, and you can see all the extra information there on the right-hand column. Okay, so then that's a little bit more about hand hygiene. Okay. So moving on to section 3. So a note about section 3. Section 3, over many years, even before I came to UNC Healthcare, over many years, probably over the past 10 years, has been traditionally the lowest scoring section in this survey tool. There's just a lot of things we can find to give people a deficit for, and don't worry, I'm going to talk more about deficits in a minute. It's not a bad thing. Many times clinics are very happy to have a deficit because that gives them leverage to get these things fixed that they may have been complaining about for a long time. You can see storage and use of supplies. Clean and sterile supplies are stored appropriately. Patient care supplies stored at least 36 inches from a sink. We still do run up against that sometimes. We still sometimes have to install splash guards, and that's okay. We're okay with that. We just need to make sure all of our clean and sterile patient supplies do not get splashed with hand wash water. Nothing can be stored nothing can be stored on floors. To the right there, you can see anything on a floor or stored on shelving on the floor has to be 8 inches up from the floor. If it is an open shelf on the bottom, that bottom shelf needs to be covered. We get this hard, very thin plexiglass that we put on the bottom of these wire shelves, and it just needs to be on that bottom shelf. Shipping cartons, we don't want them over on the right-hand side again. Outer shipping boxes should not be left in clinical areas. We seriously discourage cardboard storage in any of our clinical areas. And I think once clinic staff hears the story of why, and probably most of you know this, of course, cardboard harbors vermin eggs, most particularly cockroaches. And additionally, then once the little cockroaches hatch, the cardboard is their food. So you've got a little village of cockroaches if you're storing things in corrugated cardboard. That's corrugated cardboard. But we also don't like the single layer cardboard as well. Those things can't be cleaned. We just want to make sure that we've got things stored in plastic that we can clean things in. And of course, that plastic has to be clean. Okay, then supplies are within expiration date. That's a no-brainer there. Moving on to D, moving on to E now, clear separation of clean and dirty activities. We're able to use, that's kind of a catch-all element there. There's a lot of things we can put under there, that many things we can't even imagine today that we're going to find, and you're going to trip over when you go out there to look at your outpatient care areas. And of course, items labeled as single-use only are not reused. We teach vehemently, may I say, we teach vehemently, if an item is labeled for single patient use or single use only or one-time use only, that we just cannot use it more than once. It's a violation of federal law to do so. So that's what we got to do. And some of these things, like some of the things, it's kind of silly that they're labeled single use, but if they're labeled so, we've got to do what the FDA says, and we've got to go ahead and follow that, what's on the label. Risk analysis. So I can tell you this was kind of a new element in maybe 8 or 9 years ago. We were walking through with a Joint Commission surveyor, and a dermatologist was doing a flap graft repair in an exam room, and the Joint Commission surveyor did not cite us for that. And there's reason for that, but thought that it was probably best done either in a positive pressure procedure room or in an OR. So we put this in there to address that. And you'll see to the right there, where new procedures and equipment are commissioned pursuant to infection control consultation where appropriate. And of course, we've looped in, or we've gathered in, construction in this section 4 as well. New construction or renovations are conducted in compliance with our construction policy at UNC Healthcare. Those of you that are going to have oversight for construction and outpatient care in North Carolina, it will be a challenge at first. Things to remember there, that there is, if you are constructing or renovating an outpatient care area that is business occupancy, that is, it is not ambulatory care occupancy, nor is it hospital occupancy, but it's business occupancy, there are no design codes for those healthcare facilities in North Carolina. We have gotten around that and strengthened what we see as a gap in North Carolina construction for healthcare facilities by requiring, no matter where we're doing construction, we have to follow the FGI guidelines. That's the Facilities Guideline Institute for construction in healthcare facilities. They now, in the 2018 version, have 3 different books. One's for inpatient hospital, one's for outpatient facilities, and I think the other one is for long-term care. It's available electronically. Of course, none of it's free. Yes, none of it's free. So we are very careful to make sure we're compliant with that ambulatory book of the FGI 2018 guidelines. And it gives us a lot of strength out there where we didn't have any before. So we're happy about that. Okay. Medication management, you can see here in a nutshell, what we don't have Pyxis or Pixi. I think the plural of Pyxis is Pixi. We don't have Pixi out in many of our outpatient care areas. We have more Pyxises now than we had before, but we still have meds up in cabinets, locked cabinets. So if that's the case, when we open those cabinets, those medication cabinets, that medicine must be lined up like little soldiers. And we're not overstating it when we say medications are sacred. We need to care for them very, very carefully. And according to all the United States Pharmacopoeia, USP guidelines in state of North Carolina, the Pharmacy Board has adopted the USP as their pharmacy law in North Carolina. You may want to familiarize yourself a little bit about that as well. There are special challenges with outpatient care that inpatient IPs typically don't have. Inpatient infection preventionists have a fairly robust backup with pharmacy. Many times, however, once we move out of that hospital and into outpatient care, we lack that pharmacy backup. So it's good for us to be educated on what pharmacy expectations are in our outpatient care areas. And if you can get pharmacy backup, lobby for that, try to get it. They are truly the experts on medication management. Okay, so let's take a little excursion here out into unsafe injections. Let me turn my pages here on my desk. Okay. Remember I said at the beginning we're going to talk a little bit in depth about unsafe injections and about instrument processing. So let's talk a little bit about unsafe injections. But first of all, let's look at these two photographs I have. Now, the top left photograph I found on the internet. Hooray, I'm very happy about that. But you can see the issues there. These are syringes laying on something into a vial of medication, I guess getting ready to be drawn up to be injected into a patient more quickly. Now, we still occasionally have to have a conversation with our healthcare personnel about our convenience versus patient safety. Patient safety must trump our convenience. It doesn't take long, and I'm talking about a matter of seconds, to pop that vial cap off, wipe it with an alcohol wipe, and pull up your medication. It truly is seconds, and those of you that are nurses or have managed medication before are aware of that. So I was glad I found that photograph on the internet instead of in one of our areas. But let me take you to the bottom right photograph. You can see the vial there in mid-screen to the left that's open. That's a vial of bicarb. Now, bicarb is always single dose, which means once you pop that top off and you drop what you need, first of all, it has to be administered within an hour per USP 797. It must be single dose vial. Medications must be administered within an hour. And of course, it should never have been put back into this drawer. So, okay. So just a few items there to launch us off into our discussion about unsafe injections. So from the oneandonlycampaign.org, the website's there at the bottom right, oneandonlycampaign.org. It is a wealth of safe injection free stuff for us out there. Posters, pamphlets for healthcare people, pamphlets for the layperson. I've used many of their media for in-services. So I urge you to go to the website and see what they've got. It's really pretty amazing, the stuff they have out there. So they define a safe injection as it does not harm the recipient, does not expose the provider to any avoidable risks, and does not result in waste that's dangerous for the community. All right. So let's look at a few things that have not been very good out in our outpatient care. In 10 years from 98 to 2008, now that's a 10-year span, it was 33 outbreaks were reported. 33 outbreaks were reported in outpatient healthcare settings. 12 were in outpatient clinics, 6 hemodialysis, 15 in long-term care facilities. Of those 33 outbreaks, 448 persons acquired hepatitis B or hepatitis C infection. So what that means is those almost 450 people came to their healthcare provider that day and left with hepatitis B or hepatitis C. They didn't have it when they walked in, but when they walked out, they did. So the mechanism of these infections, of course, was patient-to-patient transmission through the failure of the healthcare personnel to adhere to fundamental principles of infection control and aseptic technique. All right, so that's 10 years from 98 to 2008. Now, we had a watershed event in 2008. Some of you probably know what that was. If you don't worry. We're going to get to that. We're going to see what happened. There was a watershed event in 2008. So in 2008 to 2013, the ensuing 5 years, we had more outbreaks reported, and 94% of those occurred in non-hospital settings. All right. So I know this is difficult to read. The good thing, if you're on your computer, you may be able to say a little bit. This was an actual cut and paste. There is a reference at the bottom, and you may be able to see that reference. I can't see it. I've got a little bar over it, but there's a reference for this document at the bottom. Outbreaks and patient notifications to outpatient settings, selected examples for 4 years from 2010 to 2014. But to the right there, just take note. In those 4 years, 22,593 patients were notified that something went awry during their healthcare visit, and you can see the breaches here. Reuse of syringes, failure to properly reprocess reusable medical equipment, complex preparation, compounding, reuse of syringes, multiple procedure and infection control breaches were identified. So you can see lots of issues going on here that notified those 22,593 patients. 86% of those were directly related to unsafe injections. That's a big deal. We still have small, unaffiliated or unsurveyed that are affiliated with our large healthcare system, but unsurveyed clinics out there that it's always, for the last 12 years, it's been my goal to make sure that people are taking note of those and getting out there and seeing what's going on. With always, we walk into a clinic, especially the first year or so, with the perspective of they have never been told these things before, and we're there to help them, and not in there to to cause them any grief or harm, but we're in there to help them and to make things right. And I think that's been well received over our years in outpatient care. Okay, so let's look at some specific examples. In New York in 2001, so this, of course, these were reported to health departments. This is how we found out about these. These were all reported up through the CDC, Centers for Disease Control in Atlanta. So an MD was reinserting used needles in multi-dose vials of fentanyl, subsequently used the medication from the contaminated vial on at least the next 18 patients. So when investigators from the New York State Department of Public Health came in, they looked at their medical supply orders, and it revealed that 4,950 needles were required for the corresponding number of procedures performed. 4,950 needles were required for the corresponding number of procedures performed. However, only 600 needles have been ordered by the clinic. This resulted in 12 clinic-associated hepatitis C infections, and my guess is there have probably been many more since then. So in Nebraska, September 2002, 4 newly diagnosed hepatitis C infections received chemotherapy at one ambulatory care cancer clinic. Well, because nursing was drawing up and reusing the same syringe to perform a saline flush, and a new syringe was used for each patient, but 500 cc solution bag was used for multiple patients. So that resulted in 99 clinic-acquired hepatitis C infections, and of course the oncologist and RN licenses were revoked. By the way, that has changed since 2008. Licenses were not... the powers that be are no longer just revoking licenses when there have been intentional breaches, and we'll look at that in more depth. New Jersey, 2009, hepatitis B transmission related to the reuse of single-dose vials and common source saline bag. We saw that in the outbreak before. Excuse me. This resulted in 4,600 patients being notified of their potential exposure to Hep B, Hep C, and HIV. 29 cancer patients were infected with hepatitis B, and the MD had the license revoked. Tragic situation there. You've already got cancer, and then we're going to load hepatitis B on top of that. So very sad. Then Delaware in 2012, 7 patients were infected with MRSA secondary to joint injections. They were reusing single-dose vials. Some of these infected patients required an average hospital stay of 6 days. So that's a big thing. And if you're a new infection preventionist, or you've not spent much time in your outpatient care and you're going to begin guys, it doesn't want to advance for some reason. Hold on, I think it's gonna.
Yeah, just a little disconnection, sorry.
That's okay, that's okay. Stand by, everybody. We're gonna get right back up here. Turn my pages and.
All right.
All right, let's see here, guys. Let me click on resume slideshow and see where it takes us. Oh, super duper. Okay, great. So Massachusetts in 2012, If you've been in healthcare since 2012, you probably heard about this situation. The New England Compounding Center, methylprednisone acetate vials contaminated with a pathogen, including aspergillus, through this New England Compounding Center. Because of improper sterilization and testing of those sterilizers and improper management of the sterilizers, that was one of the factors in these contaminated methylprednisone vials. But look at the red text there. 751 patients were infected. 64 of those patients died from their infections. These were typically medications were injected into spinal canals for pain patients, so you can imagine how very, very serious this situation was. The New England Compounding Center, the two pharmacists that owned that pharmacy, surrendered their licenses 7 days after the start of investigation. I can also add to this, since then, these two pharmacists have each been indicted on 23 counts each of second-degree murder. 23 counts each of second-degree murder because of what happened here. Now, it's important to keep in mind, these were not accidents at this New England Compounding Center. One of the sterilizers, perhaps both, but I know one of the sterilizers was found to have mold inside of it. Now, mold won't grow at 274 degrees for 4 minutes. It will kill everything in there. So there were very, very serious breaches. Sterilizers were not maintained, and it resulted in this tragic situation. But important to keep in mind, these were intentional breaches, just like what we're going to see in Las Vegas. These were intentional shortcuts that put these patients at risk, and that, therefore, hence the criminal charges. We didn't just lose licenses. We were indicted, and some of us in jail. Well, you know, not us, not me, but anyway, you know. Okay. So I know I've mentioned Las Vegas a couple times, a very tragic situation out there in 2008. And we had the joy at APIC in June following this outbreak in 2008. The director of the health department there came and gave a talk at APIC, which was amazing. It was so nice. It was really impressioning. It impressed me to hear from the guy that was on the front lines. He told us that he doesn't get typically 4 acute hepatitis C's over a span of time on his desk. And suddenly in a week's time, he had 4 acute hepatitis C's reported. So kind of a branch of that, if you will. If I've ever thought, and there have been times I've thought, that these reportable diseases aren't doing any good, had hepatitis C not been nationally reportable, this outbreak may still have been going on. So it was a very good thing that it was caught via the national reporting system that we have in place for these very tragic diseases. Okay. So you can see all the data there to the right-hand side, 6 known acute cases linked to one location, genetic match of the 4 patients with procedures on the same date. These unsafe injection practices occurred over time. Of course, as we saw in one of the clinic areas, the anesthesia logs, let me give you a little background here. So the clinic was and had been directed to reuse single-dose vials of propofol. Now, propofol doesn't come in a multi-dose vial. It only comes in a single-dose vial. Propofol only comes in a single-dose vial. The CRNAs, the anesthesia tech, the RNs there have all been instructed to reuse that vial until it's empty. They also were instructed to reuse syringes. They were changing needles, but they were instructed to reuse syringes. So you can see the outcome there, and we're going to get to exactly how that outbreak happened. 114 patients have acquired an outbreak-associated case of hepatitis C, and I would guarantee you we've got more patients than that at this point. 53,000 patients notified. 53,000 patients had to be notified of their potential exposure to hepatitis C, hepatitis B, and HIV. Now, that's not to mention all the other nasties we can be transmitting via unsafe injections, but those are our big 3, right? So Teva, who made propofol, of course, they were sued, and at least 200 million suits against Teva were won by patients. 2 of those patients have died with their hepatitis C infection. The MD was convicted of 2 counts of second-degree murder, insurance fraud, and negligence resulting in bodily harm. And at the time I made this slide, he was eligible for parole in 18 years. He has since died in prison. He had a couple of strokes. So it was a very tragic situation that was completely avoidable by people simply doing the right thing. And of course, this clinic had no infection control oversight. Okay, so this is how that outbreak rolled out. So when CDC came in to help with the investigation, of course, now this is an endoscopy center. So what are we going to think? Who's the culprit? It's got to be the scopes, right? Well, it wasn't the scopes. They found out the scopes tested fine. The process for cleaning scopes was fine. Now that may not have passed muster today, but in 2008 it was okay. However, so then when we're doing epidemiological investigation, we do concentric circles. We start where we think the problem is, and of course that was with the scopes. The problem wasn't there. So we move out to the next concentric circle. That would be in the clinical area. As the CDC investigators were watching, they watched a CRNA draw up her dose of propofol to sedate the first patient. She picked up the IV tubing. They didn't have a needleless system. They had a needled IV tubing system. She injected the first patient via the IV tubing with the propofol, stepped back. That patient went off for endoscopy. As she stepped back, she took the needle off the syringe, put a new needle on the same syringe, and went back into the same vial of propofol. Now, of course, if we thought up until then that what was in the patient wasn't in the IV tubing, we found out then that was wrong. Whatever is in your patient is in your IV tubing and is in your IV bag. Whatever is in the patient is in the IV tubing and in the IV bag. So that patient had hepatitis C, right? The index patient. So when she stepped back and took the needle off the syringe, not knowing there was hepatitis C in the syringe now, and put a new needle on the syringe, thinking that was safe, of course, then she went back into the vial of propofol. Now the vial of propofol is contaminated with hepatitis C, and any patient down the line has been infected with hepatitis C or has the potential for that. And you can see this graphic from the CDC, the references up there at the top. If you need more information on that, I do go ahead in there, read this report. It is shocking and will open your eyes. And I don't know what goes wrong in some places, but of course, everybody there realized that whatever they were doing was not worth the cost. Everybody lost their licenses. More than one person spent time in jail. I would reckon there are probably still people in jail in Las Vegas, Nevada. And of course, not to mention the deaths and the people infected with hepatitis C, hepatitis B, and HIV from that clinic. Okay, so since then, like I said earlier, it was a watershed event. Centers for Medicare and Medicaid Services sponsored a study through the CDC in 2008. They went out and studied 68 ambulatory surgery centers, 32 in Maryland, 16 in North Carolina, 20 in Oklahoma, with the focus on hand hygiene, injection safety, equipment reprocessing, environmental cleaning, blood glucose monitoring equipment. So 46% of those 68 ambulatory surgery centers had at least one lapse in infection control, 17% had lapses in 3 or more categories, and commonly 28% were lapses in injection safety, particularly single-dose vials used for more than one patient. 28% with lapses in equipment reprocessing, and almost 50% with lapses in blood glucose monitoring equipment. If you're not familiar with that little innocuous look device, doing this infection control were common. We work every day at UNC Healthcare, and I know you guys will too, out there to make sure that's not the case in our healthcare systems. All right. So since then, of course, and then subsequently, these are the CMS came out with 2 multi-page documents specifically for inspecting infection prevention practices in acute care. Those of you in hospitals, there's a 42-page version for inpatient hospitals. There's a 17-page version for ambulatory surgery centers. Easily found. Google them online. You'll find them. I do strongly recommend you print those off and spend some time with them. If CMS, DHSR, whoever your state agency is for CMS in your state, If they do come to your facility following up on infection control complaint, they will have one of these documents in their hands, and they will make sure as they go down step by step that we are doing everything that those documents say we need to do. Okay, so so that's enough about that. Let's go ahead. We're going to talk a little bit more. Let me get my pages caught up here, guys. So sorry. I want to make sure I'm seeing. We got a little bit more about safe injections. This is the section on the survey tool, section 6. The new survey tool, the 2018 survey tool, it's not section 6 anymore, but there's still a very robust safe injection practices section. But just let me tell you, this section was drawn mostly from that CMS survey tool that we just looked at, the 17 page for ambulatory surgery centers and the 42 page for inpatient. This was drawn mostly from that. So, good thing to have. Okay. All right. Of course, then we also have other help for us. We have the APIC position paper, a very robust paper. There's your citation for that. You can go find that online. Very, very key thing to read. It gets into really, I don't want to say the weeds, but it gets into interesting situations like, well, if I have a multi-dose vial, can I use it multiple times for the same patient during the same procedure? There gets to be a lot of detail and, believe it or not, some complexity with safe injection practices when we start talking about, say, single dose vials for the same patient for the same procedure. How many times can I go back into it? And this paper, this APIC position paper, addresses that. And of course, there's another shameless dig for the one and only campaign.org. Wonderful. You want to just bookmark that on your computer and go to it often. All right, so now this picture is from my phone. I just want you to take a look at that. So this is a multi-dose vial of lidocaine, But notice the red handwritten words down there, buffered. Well, it was buffered with single-dose bicarb. And then this spike was left in all day, which, by the way, we're not allowing this anymore. But like I said, our goal is to get out there and find these things so that we can stay safer. So that was my goal that day, to help them solve this issue. The nurses, of course, were using this to make a little bleb before they start an IV because they were absolutely very, very committed to making that a more comfortable procedure for their patients in an ambulatory surgery center. So we came up with a solution that they can have this lidocaine and bicarb compounded by a compounding pharmacy and put into pre-filled syringes for them, per CMS and CDC advisories on how to do this, how to find a compounding pharmacy. By the way, there is instructions on that or recommendations on that from CMS and CDC. So at a cost of $7 per pre-filled syringes, those nurses wanted to do that, and their leadership said okay. So that was a problem solved, which turned out really, really well. But notice, now here's a little bit of complexity. Well, what do we do if we're compounding? First of all, we don't like compounding for nurses in a non-USP 797 environment, but there are stipulations to be able to do that, but make sure we're following USP 797. But what do we do with a single dose medication once we put it into a multi-dose medication? Well, we have always said that turns this whole thing into a single dose med then. This is all single dose. We can't use it for multiple patients. So we err on the side of caution there. And if we're adding a single dose medication into a multi-dose medication, that turns it automatically into single dose, can only be used for one patient. But once again, they solved that problem by sending bicarb and lidocaine to a compounding pharmacy that was approved to pre-fill those syringes for them. So we still have a single dose syringe, right? But it's properly done under a hood under USP 797 regulations. Okay, just a little bit of the complexity we can get into with injection safety. This is actually a one-page flyer that we made. We wanted to address the fact that we were finding reusing single-dose vials out there, and we wanted to address the fact, so we went ahead and prepared this. And we still have that once in a while. We still do distribute this single-dose medication vial. Okay. All right, so back to the assessment tool. I am keeping an eye on the time. And let's go ahead and we're going to look at linens very quickly. Linens in a nutshell, they need to be covered at UNC Healthcare. You can see on the right-hand side there, clean linen must be kept covered, if not in a closet, drawer, or cabinet specifically designated for linen. If your linen is in a clean utility room, we have to have it covered. If your linen is in a linen cabinet, it doesn't have to have an additional cover. Those cabinet doors just have to be closed. Also, linens have to be laundered according to UNC Infection Control's laundry and linen service policy. You may want to keep an eye out there if you have outpatient areas that are off campus or off site, not attached to your hospital. You want to kind of keep an eye out for washer and dryers. There's APIC recommendations also on healthcare linens. So you've got a lot of leverage out there. If people are still washing linens in their clinic, there is leverage out there to help them stop that and get contracted with a healthcare linen service company. Surface disinfection, here we're talking about how to clean our toys. We're talking about non-critical items. Those are things such as blood pressure cuffs, exam tables, etc. Patient care equipment, more stuff here about how to clean those. D, areas identified as nursing responsibility are cleaned appropriately. We know some of our areas, for example, medication storage areas, environmental health, EVS, environmental services won't clean those areas. That nursing has to clean those themselves. And then, of course, point of care devices are cleaned according to policy. This is our blood glucose monitoring element here. We want to make sure that those are cleaned between every single patient with a hospital grade approved disinfectant. Instrument decontamination and pre-cleaning. Okay, we're going to kind of launch off into instrument processing here. I'm going to take you through these sections quickly, but then we're going to talk more about instrument processing. Once again, if you are over areas that are doing instrument processing, these are key things for you to have your hands on. You want to make sure you're checking these areas. So about pre-cleaning and decontam with enzymatic detergent, we got to make sure those are labeled correctly, that they're measured correctly, that the ratio is right, and items are managed consistent with the OSHA regulations and policy. Let me back up once because it's been an issue that we have tried. Let me take you to 9B. This is the element that talks about you must transport a dirty piece of equipment, and that is a semi-critical or critical piece of equipment. That is a piece of equipment that's used on a mucous membrane or normally sterile tissue from point of use to the instrument processing area in a leak-resistant container marked biohazard. That is OSHA law. One would not think that's been so hard to attain, but that has been a very difficult thing for us to attain in our large healthcare system. However, we have finally, we ganged up on it, and by gum, I think we finally got a toehold on there, and I think we're winning that fight. Okay. High-level disinfection, folks, if you are over an area that does high-level disinfection and you're not as educated on that as you'd like to be, get more education on high-level disinfection. It is a highly complex process, a time-consuming process, and we just need to know as IPs what we're looking at. There is no margin of error with high-level disinfection as opposed to sterilization. High-level disinfection done perfectly, correctly every single time has no margin of error. So we need to do our best to make sure that we're doing it properly. Sterilization, we're going to talk a little bit more about sterilization here in the next few slides. General decontamination, high-level disinfection, sterilization. Big things here, guys, and we're going to talk a little bit more about this. We don't have time in this presentation to really dig into these instrument processing sections, but there is plenty of education out there for you. So let Amy know, let Spice know what you're looking for, and they can help guide you to more education. Proper PPE, let me direct you to 12A. I'm going to say anecdotally about 6 years ago, when we went out to our clinics to see how well people were complying with the OSHA regulation for PPE. Now, OSHA is the law. We don't have a choice with OSHA, and we're careful to tell people that, to educate our staff on that. OSHA is the law, and OSHA says you must wear the PPE to protect you from blood and body fluids. It's not a choice, it is the law. We probably had 30% compliance in our large healthcare system when we moved out into ambulatory care areas. I can tell you now, however, and I'm so proud of that, that we can walk into any instrument processing area and by gum, people have their PPE on. And I will tell you, maybe some of that is that we've scared them into wearing it, but I'm okay with that. It's to protect them, and they just simply have not been told before that what you are washing does have hepatitis B, does have hepatitis C, does have HIV, and not to mention all the other pathogens we can put on an instrument that is not going to show you it's there. You must protect yourself. So we've gone heavy on that, and I'm going to tell you, I'm proud that our staff is protecting themselves and doing the right thing, because the last thing any of us want to do is come to work to wash instruments and go home with one life-changing disease, or lose an eye, right? Because we're dealing with hazardous chemicals. We had a presentation by one of our industrial hygienists about a year ago, and he said a very thing that I quote all the time, and it kind of woke me up. He said, if you lose an eye, you're going to have to start your life over. And I've always relayed that on. We work with high-level disinfection, always uses hazardous chemicals. We need to make sure we're fully protecting all of those portals of entry, if you will, on the front of our face. I know I'm motioning here if you can see my picture, but I want you to stop for a minute and count the number of portals of entry, in that chain of infection, right? The chain of infection. I have 5 portals of entry on the front of my face. I must protect all of those portals of entry. And we have done a great job here at UNC achieving that and maintaining that attainment. It's very gratifying to know that people are understanding that they need to protect themselves. Okay, that is my soapbox, as you can tell, with high-level disinfection. Okay, so let's dig into instrument processing in outpatient care facilities. Of course, when we can move a patient out to outpatient care, it saves time and money, right? But it also brings a heightened risk of infection to patients and staff, because we're doing much more complex and invasive procedures in outpatient care than we have ever done before. Okay. So who tells us how we're supposed to clean these devices? Why can't I just wipe everything off with a sandy cloth? Because we have the Spalding classification scheme, to which we must be consistent with. All major societies and healthcare advisory institutions subscribe to the Spalding classification scheme. It's a clear, logical approach to disinfection and sterilization. It breaks all of our instruments we're using into 3 categories: non-critical, semi-critical, and critical. Non-critical devices are those things that touch intact skin: blood pressure cuffs, stethoscopes. I'm going to give you another example in a minute. Semi-critical devices, however, those items contact mucous membranes or non-intact skin. Semi-critical. They must therefore be at least high-level disinfected. Non-critical devices, we can wipe that stuff off with a sandy cloth or your disinfectant wipe. Or your disinfectant spray. We can clean those non-critical devices with that. But once we move into semi-critical devices that contact mucous membranes or non-intact skin, we must at least high-level disinfect them. The critical devices, by the way, now those contact normally sterile tissues. Those critical devices must be those critical devices must be sterilized. They can't be high-level disinfected. They must be sterilized. Okay, so here's an example. Let's say I've broken my arm. Today's the day I get to go in and have the cast off of my arm. I go into my orthopedist. They saw the cast off. It has that cotton wrapping underneath the cast. My skin is intact underneath the cotton wrapping. They can take the scissors off the sink and cut that wrapping off. Wipe those scissors off with the sandy cloth when they're done and put them back in the cup on the sink. Okay. Those scissors, according to Spalding classification scheme, because they don't contact mucous membranes, they don't contact non-intact skin, they don't contact normally sterile tissue. Those are non-critical scissors. Okay. Now, I have a chat. I don't know, Amy, if you're on the chat, it says no sound. I wonder if other people have sound. I'm going to continue on. I'm going to think I still have sound. Okay.
Yeah,
Okay.
I just would encourage folks to make sure their microphone is uh, muted. Um,
Great. It looks like everybody else chiming in has sound. So we're sorry about the person that doesn't. So apologies.
yeah,
Okay. So scissors. Remember we just described a non-critical pair of scissors, right? Now let's talk about scissors, right? Same device, scissors, but now I'm in an OR and I'm cutting adhesions in an open abdomen. Well, what are those scissors now? Now, those scissors are a critical device. So the moral of this story is know how those devices are used and where they're used before you can ascribe them to a certain category in Spalding classification scheme. So that's the key thing there. Okay. Of course, a solution to all the Spalding classification scheme is switch to disposables wherever possible, whenever possible. And dear IPs, there are disposables and there are disposables. If you want an area to trial a disposable, I would recommend don't buy the cheapest one. Buy the most expensive one and see what they think about that. We have found disposables that are actually more effective than some of the reusable devices we were using. So, of course, and you can imagine, I know you're sitting there thinking, well, what about the expense? We always must factor in staff time for instrument processing whenever we're figuring expense of a device. We now have disposable colonoscopes and disposable bronchoscopes that are $199, $250, and the peer-reviewed literature says it costs almost that much in staff time and consumables to high-level disinfect those colonoscopes and those bronchoscopes. So we're actually saving money on many of our disposable devices. Okay. So here's a picture. I want to show you those IPs, and actually this week, IPs, you're going to see a central processing department in a hospital. And keep this picture in mind because what you're going to see looks nothing like this. This is an instrument processing area in a clinic. Now, I'm happy to report to you, this has all been renovated and it's correct at this time. However, this wasn't even in a room. This was at the end of a hallway in an alcove, an area where they were sterilizing and high-level disinfecting ophthalmic instruments. Down below the sink there, you can see we have the sink cabinet door open. I want you to look at the little stainless steel container down there. That's where they did their high-level disinfection. So is it up to standard? Absolutely not. Is it barely legal? I don't know. The thing is, staff was very, very, in outpatient care, most times, we must work with the physical plant that we have. And this was the physical plant we had. So we had to work with this. We had no other place to put this stuff. There simply was no other space until they renovated or moved. This is what we had to work with. So what we did, if you'll follow along with me, I'm going to take you from the left-hand side of that counter next to the sink. The left-hand side is the dirty side, and I know this is a stretch. Left-hand side's the dirty side. That container, the big basin you can see turned over, that's where they mix their enzymatic detergent. The sink moving over there, moving to the right now, the sink is where they rinse the enzymatic detergent off. Of course, this was now a dirty sink. I'll come back to the eye wash in a moment. Then you can see to the right of the sink, this is where they dried the instruments that are getting ready to go in the sterilizer. They're moving even farther to the right. And then in front of the sterilizer, you can see where items that had been sterilized had come out. As soon as they were out of the sterilizer, they were moved back into their procedure room, so they were out of this area completely. Once again, substandard, absolutely. But at the very beginning of this presentation, I told you, you will always make things better. We may not always be able to get things up to standard, but my goal has always been to make things as safe as possible for staff and patients. And we did this out in this clinic. As, may I say, dreadful as this picture looks, I didn't get a before picture, so that's probably a good thing. So, okay. Yeah, I see the chat. Is that a drinking water cooler on the right? Absolutely, but it was distilled water for their sterilizer. They weren't drinking it, so yay for them. Okay, so back to that eye wash IPs. That eye wash, OSHA says you must have one motion to activate your eye wash. So first of all, notice the eye wash is underneath a cabinet. Notice also, you can see you've got to turn the water on, right? There's a little button there. I don't know if you can see it, but on the gooseneck faucet, you can see the button there between the two eye wash pods. You have to pull, so you've got to turn the water on, pull that button out, and then hit your head on the cabinet when you're getting your eyes over the eye wash to get your eyes washed out. Okay, so that's not an OSHA compliant eye wash. And of course that, as soon as they renovated, of course got fixed as well. Okay, so lots going on in that photograph. Here's another photograph that I want to point out the double sink here. The clinic, very, very wonderful to them. Kudos for them. They labeled one sink biohazard. They figured the other sink was clean. Now, we know, however, that they're either both dirty or they're both clean. So both of those sinks were dirty. This clinic underwent, and this was years ago, we actually it helped them get a $150,000 renovation. This is an ENT clinic that were doing those tiny little scopes. We automated their scope processing activities and actually did great things there with the clinic's support. They were wonderful to work with. So, okay. So this is a before picture, by the way. I don't have an after picture for you. Okay, so here's some of the instruments we use in outpatient care. You can see flexible scopes, you can see stainless steel items, you can see semi-critical items, you can see some critical items there, some of the instruments. These are some of the sterilizers you'll see out there. I'm happy to report to you that this sterilizer on the right has been replaced with a brand new model. Yay! Very happy about that. These are other models of sterilizers you can see here. Steam sterilization. We love steam sterilization. Dear IPs, and you don't share this with anybody else, but we have done research at UNC Healthcare, and you'll probably hear talk about this from Dr. Ritala later this week, that you can do some things wrong. You can leave some things on your instrument and run it through the steam sterilizer, and that stuff's still going to be on there when it comes out, but it's going to be sterile stuff. Of course, we need to still go back in and sorry, I'm distracted by the chat box. Sorry, we'll try to get back to that question. Sorry, guys, it was a question about the clean and dirty sink. So steam sterilization, though, it is highly, highly, highly effective. It is so robust. The cycle is easy to control and monitor. It penetrates medical packing and device lumens to a certain extent, lumens. And it's least affected by organic and inorganic soils. And of course, it's a rapid cycle time. It's non-toxic to patients and staff. We just love steam sterilization. So whenever we can do that, we love to do it. Of course, you can't put a flexible endoscope in a steam sterilizer. There's a lot of things that are heat labile that we can't do in there. And we have to punt over to different processes. Okay. Let's do a little bit more about steam sterilization. So let me get my pages caught up here, guys, so I know where we're going. Bear with me. Okay. So we're going to a little more detail about sterilization. Every sterilization pack has to have a class 5 integrated indicator or chemical indicator. I many times just fall back into my own language of saying this is a chemical indicator. Every single sterilization pouch, pack, open tray, whatever, has to have a chemical indicator in it or on it. You may be saying, well, why are we sterilizing things on an open tray? Remember I said semi-critical devices must be at least high-level disinfected? So for example, a vaginal specula, that's technically a semi-critical device. If you have a clinic that's got a steam sterilizer, I would urge them to steam sterilize them. Of course, each in a peel pack would be great because that way they're kept clean. But technically, they don't have to be kept sterile after they come out of a sterilizer. So that would be the only time we could do anything on an open tray. If it's a critical device, you have to have a means of maintaining sterility from the sterilizer to the point of use until it's used. So in that case, everything has to be in a peel pack or a pouch, either in a wrapped, or those are basically basically the two large ones, the two methods of maintaining sterility we have in our outpatient areas. Biological indicators. I'm sure some of you have seen some of these things. The top left picture there, that's a little steam biological indicator incubator. The center on the bottom row is, again, a larger incubator. You can see some different brands of biological indicators here. We use 3M A test at our site, but we have another site up the road that uses a Steris product. And this is I'm not supporting any of these products whatsoever. It's just to let you know there are different brands out there. Okay. Biological indicators should be used at least weekly, and I may say must be used at least weekly with each load that contains implants, and ideally daily. The BIs, the biological indicators, must be intended specifically for the type of your sterilizer in use, as well as the cycle you're running in your sterilizer. And your biological indicator instructions need to tell you that. Okay, these are intended for example, over on the right-hand side here, that's a little Sterad hydrogen peroxide plasma sterilizer. Those cannot use a steam sterilizer BI or a steam sterilizer chemical indicator. They have to have one specific to their type, that type of sterilizer. Okay, monitoring the sterilization cycle. I'm happy to report, as of 2 months ago, we have finally gotten rid of all of our countertop sterilizers that did not have a printer. CMS will cite us if they come in and they find we're using a sterilizer without a printer. There's absolutely no other way to monitor time, temperature, and pressure without a printer on those sterilizers. So the sterilizers that do not have printers should not be used. So those are our physical parameters you can see. That is one way of monitoring the sterilization cycle. Another way, of course, is our chemical parameters, those chemical indicators we looked at, that class 5 chemical indicator. And then, of course, we have the biological parameters, and those are our biological indicators that we use here in our outpatient areas. We use weekly. Of course, nobody's sterilizing implants in outpatient, but in our central processing departments, they run biological indicators. Some of them run with each load, but certainly they are run every single day. Okay, so your clinics may process semi-critical devices manually, so we're kind of changing gears now into high-level disinfection. You may be doing manual process for high-level disinfection, or you may have automated endoscopy processors. You have some examples of those supporting devices there. Once again, I just want to remind you, if you are doing high-level disinfection in any of your areas, you want to become educated on that. It's really, really important. It's so complex. There's one way to, oops, sorry. Sorry, I had a little hiccup there. Of course, there's this wonderful, as you can, I know, I'm jaded. I love Dr. Rutel and Dr. Weber, but of course they write the guidelines for all of America to write, and that's the guideline for disinfection and sterilization in healthcare facilities from the CDC. That is a fundamental document you will want to have in your library for sure. Other resources here for you. There's a great paper out there from Clinical Infectious Diseases from 2004, still relevant today, disinfection and sterilization, what clinicians need to know. There's also the Multi-Society Guideline on reprocessing flexible gastrointestinal endoscopes. There is a 2016 version, guys, so I'm sorry about the old slide, my apologies. That is free online. Please go get that, even if you're not doing gastrointestinal endoscopes. If you're doing any high-level disinfectant, this is a wonderful guideline to have. If you get to a step that talks about lumens or drawing a lumen and you don't have a device with a lumen, just skip that step. But that's another thing that you should have in your library. But let me stress manufacturer's IFUs, manufacturer's instructions for use. For every device we are sterilizing or high-level disinfection, those must be on file in the area in which this instrument processing is happening. That has been a challenge for us, but we're working on it. We've got a toehold on it, once again, like I said earlier, but we've got manufacturer's instructions for use. They must be available and for all of us there. Now, there's this large database that we can sign up for, and we have a subscription to it. It's called Amy. There she comes. She's coming back.
Here
There
I
you are.
am. Yes.
Hello.
Hey. Let's see.
Anyway, I'm going to keep talking, Amy, until you get the slides back up, okay? They can still hear me. Is that okay?
Yeah.
Okay.
Yeah.
So we're going to go back to the survey tool, guys, and there's not a lot left on there, and I know that we wanted to leave a few minutes for questions. So I may just briefly tell you what's on the, there we go. Okay, so we have the, thank you, Amy.
Yeah, sure.
Let me control your screen. Okay. Let's see. And Amy, do you need to get it in presentation mode for me, or do I do that?
I think you can do it better, more easily. Yeah.
Oh, I can't get to it though. So sorry, guys. All right. Well, there's the isolation section. Just letting you know what we do in almost all of our outpatient areas is that we follow standard precautions. Now, that's been a big education thing, right? Standard precautions, dear outpatient folks, doesn't mean you do nothing. It means, thanks, Amy, it means that we must protect ourselves in any method we think is appropriate from any patient we think we need to protect ourselves from. I have had somebody, when we asked what PPE meant, they said patient protective equipment. That is not what that means. It's personal protective equipment. And we talked a lot about that when I was talking about instrument processing before as well. Okay, so that's our isolation section. However, let me add on a little bit. Of course, we're a Cystic Fibrosis Foundation center here at UNC Healthcare, and I'm sure some of you are also associated with some of those. So all cystic fibrosis patients have to be on contact precautions. So when those new guidelines came out, I think in 2014, we had a massive education campaign out there to understand, of course, because cystic fibrosis patients go everywhere, to make sure that people had the PPE they needed to manage those patients properly. Okay. General issues you can see there, that's all about our environmental situations out there, ceiling tiles, no rips, no tears in vinyl, et cetera, et cetera. And then we have medication refrigerators and freezers. Yes, gosh, who thought you could write so much on medication refrigerators and freezers? Just keep in mind that the state of North Carolina is very, very interested in making sure we keep our ice right. And here, so section 16E, you see there's lots of stuff that's almost directly from the Department of Health and Human Services in North Carolina, making sure that we're maintaining ice properly. Now, we have had multiple outbreaks. The reason for that, multiple outbreaks associated with contaminated ice in North Carolina. I with new clinics, acquired clinics, I would certainly let you know you do want to go through every single line on that survey tool to make sure you know what you're dealing with, so that you can effectively help them get up to snuff. Okay. So where I'm going with all that is that, clinics I've been walking into now for 6.5 years, you get a sense of who's okay and who's not. So that's where we do with all of that. Let me click on so I can control Amy Powell's screen. Okay, so let me go ahead. So where does all this data go? Let's see here, Amy, I'm trying to advance here. Bear with us, guys. Where does all this data go? Yay, there's my where does all this data go screen. Okay, so let me just advance to this next screen. So as you saw briefly at the very beginning, where does all this data go? It all goes into a spreadsheet. It all gets tallied up. Every single section. Remember we looked at 16 sections? Okay, let me take you here. Okay. So the yellow highlighted boxes, you can see each section has its percent met, all right? There's a percentage met for each single section. Then at the bottom of the report, this is our report form, by the way, you can see the entire left-hand column is identical to the checklist, the survey tool, but then the whole right side is different. And this is where all the scoring happens. So each one of those sections gives its individual score, but then each one of those means is pooled at the bottom of the report and is taken up, see in the top left-hand corner there, that 81%, that's their overall score for their survey. Okay, so that's how that all works. We already looked at that, and we already looked at that. And that is my last slide. And I think, Amy, maybe if we have some time for questions, I know I saw a couple pop up during the talk. I know, let me kind of, one I remember, do we culture our endoscopes? Yes, we do. Let me see if I can open that chat box. Here we go. Oh, look, gee whiz, I could do it myself. Sorry. We do routinely culture our scopes, Elizabeth. We have for many, many years. In February 2018, the FDA CDC came out with guidance on culturing ERCP duodenoscopes. We actually follow that culture routine for all of our flexible endoscopes. We take one scope a week from each of our 3 GI clinics, and then quarterly we do a bronchoscope, we do some OR scopes. As you can imagine, unfortunately, we do have scopes everywhere, but of course, we're focusing largely on our GI procedure areas. So yes, we routinely culture scopes. Let me kind of move up here to Beth. Beth's question about, so you can't have a double sink with a clean side and a dirty side. That's correct, Beth. We know that whatever we're doing in a sink is going to contaminate the drain, contaminate the faucet, and it's going to splash out to the side. So that means, remember I said when we looked at that one picture with the 2 sinks, they're either both clean or they're both dirty. They can't have one clean and one the other because one is going to contaminate the other. Okay, let me kind of go back up here. If you are, am I okay, Amy?
You're fine. Yeah.
Okay, wait. Hold on, let's see one. Yeah, Amy, let me come back quickly. Amy's asking about the pessary issue. Yeah, that was a challenge for us. I think we, let's see. And questions about the access to the survey tool. Amy's going to get you that, I'm quite sure. So Amy Cremines, her question is, I don't know if everybody, I think everybody can see it. Can you clarify the water discarding process for the pessary rinse? Do staff carry the water to the hopper in an open container rinse tub, or you do some sort of watertight container? Okay, we actually carry that bath basin to the toilet. It's not covered, there's no lid on it. And that's why we, in our procedure that we just finished and we have disseminated to them, we have been very clear to do not fill that bath basin up. Use the minimum amount of water you can possibly use. And then, yes, you have to carry it to the toilet or to the hopper to discard. Right? Not ideal, but at least this way, we're not going to contaminate a hand wash sink. But Amy, a little more detail here. What we first looked at is carrying that pessary to a dirty utility room. Well, that's fine if you have a soiled utility room, right? Our 2 Urogyne areas did have a soiled utility room, and we walked it one day. Now, keep in mind the patient's in the exam room, in the stirrups, right? While you're washing this pessary. So in order to if we require them to go to a soiled utility room to keep that hand wash sink clean, it was about a 4-minute process depending on which clinic we were at. So during this time, the patient's in the exam room, legs in the stirrups, it was a very uncomfortable, may I say, awkward time for everyone. So we regrouped and realized we had to do something else. So that's how we came up with the basin down in the hand wash sink. All that water goes in that basin, minimal amounts of water, and then it gets thrown away in the hopper or a toilet. So then Elizabeth McLean, so you're asking what product do you use to culture scopes? I want to just be clear that there are no products for culturing scopes. There are products that are ATP or detect soils, organics before these scopes are high-level disinfected. And I wonder if that's what you're asking about. I'm going to assume you are, because there are no products to culture scopes. There are products to test for soils. We don't use any of those products to test for soils. And you know, lots of companies are making them. They're ATP products. You'll ask one company about it. They'll say, well, ours is not ATP. Ours tests for hemoglobin or it tests for some other human product. We've done testing here at UNC Healthcare with ATP products, and you can have a negative ATP that ranks under the 100 RLUs or whatever the ATP says. Okay, if it's under 100, your scope is clean enough to put into high-level disinfection. You can have it showing that result, and you will still have 1 million pathogens on that scope. These ATP products, these pre-high-level disinfection products, do not detect pathogens. They are only detecting certain types of soils. Now, the more you know about soils in the laboratory environment, there are soils and there are soils. There are stand-ins for human soils. They're not really human soils that they're testing with. So we don't use any of those products here at UNC Healthcare. But like I said, so we culture instead, right? Okay, the next question, Elizabeth, and I want to answer this real quickly, and I see we're out of time. So quickly, Elizabeth asked, do we hold that scope until the culture results are back? Yes, we do. We have the great joy, though, in our department, we have our own microbiologist, so she runs them for us. She knows within 2 days whether that scope can be released or not, just judging on what she's visually observing in the culture plates. We may not have the exact pathogen in 2 days, but she'll know whether or not we can release that scope. And by the way, we do follow, whether we release that scope or not, the FDA, that February 2018 FDA CDC guideline for culturing endoscopes. So I see we've reached our time, Amy, and I don't want to go on. I know lots of questions. We appreciate you all. Thank you all.
Hey,
Yes.
Judy, hang on.
Yes.
So I think, the next webinar is at 9:45.
Okay.
It's 9:30. I think we could take another 5 to 10 minutes.
Okay, great.
To answer questions. And do you see the one up in the Q&A folder with a little red?
Oh, let me click on that. Oh, okay. I see it now. Thank you. Thank you, Amy. We'll go ahead and just, Amy, give me a heads up when you want me to start, because I'll talk for days about this stuff.
Will. I'll butt right in.
Okay. So Sydney asked, I know we did not go over this, but could we possibly very quickly discuss how to handle bed bugs in the outpatient clinics? Great question. Comes up frequently, of course, as you can imagine, probably has with you. So we have actually in our department, we have these one-page documents. They're called Did You Know? So they're a DYK, Did You Know? We have one on bed bugs. So our stance at UNC Healthcare, based on the literature and on the evidence, is that a bed bug is not an infection control issue. It's an exterminator issue. So our places call exterminators, and it's all on exactly what to do is in our Did You Know for inpatient and outpatient. So we look at them as an exterminator issue as opposed to an infection control issue. They do not transmit pathogens, so that's a good thing. Okay, now back up to our chat box, and I see Amy asks, with simple steroid joint injections in outpatient practices, medications are pulled from both multi-dose and single-dose vials into one syringe. They are not mixed in a vial, but both pulled straight into the syringe. Is it best process to access the multi-dose vial lidocaine first prior to the single-dose vial of steroid? Absolutely. Absolutely. Great question, Amy. This is one of those fine details about safe injection practices. Great question. Absolutely. Also, so access your multi-dose vial first, folks, no matter what, if you are mixing in a syringe, and then go to your single-dose vial, pull up what you need. Of course, the rest of that single-dose vial has to be thrown away. This way you're maintaining the integrity of your multi-dose vial and getting rid of your single-dose vial. Also, some details associated with this. I'm sure there's some people here that are going to have ortho clinics that you're responsible for. They do lots of injections in ortho, well, just like Amy's asking about. Sometimes they'll pull up 3 different medications into a vial. You want to do your multi-dose vial first, and for example, I think our Kenalog single dose, and there's another one, another single dose that they pull all straight into that syringe. So the multi-dose vial gets pulled first. Anything subsequent from a single dose vial gets pulled second. Now, I'm sure there's more details about that. And if you need more information, you can certainly contact Spice, Evelyn Cook there, and Amy Powell. They can help you walk through this situation. It can get really complex, especially when we're pulling 3 different meds into one syringe. Now, that is compounding. USP 797 says you may compound sterile medications for immediate use only. You may not do this first thing in the morning and then use them later in the day. So there's that. Of course, also we learned that single dose vials, once you pull that medicine up, that must be administered within an hour. So just make sure that's a lot of T's to cross and a lot of I's to dot on all the safe injection practices out there in outpatient care. So you'll just let us know if you need more help with that. So, okay. All right. I've got more time. Any more questions? Let me make sure. I think we got all the questions. Let's see. Let me kind of scrolling through, and Amy will get to the survey tool. Right, Amy, you'll get them the survey tool unless they already have it. So
Yes.
And I know that I'm reading Tony's comment to Amy, more information and education on high-level disinfection. Let's see here. So I think that's all I've got, Amy.
I think that's it. Well, Judy, we certainly appreciate the presentation. I want to mention to folks that we are experiencing just an occasional little internet down. I think that's wind related today. So if y'all will bear with us when we have those little disconnect moments, I think we can work through them. Judy, again, thank you so much. To the rest of the gang, we'll see you at 9:45 with Dr. Van Dyne.
Thank you, guys. Thank you. You were great. Thanks, Amy.
Thanks a lot. Bye-bye.
Bye-bye.